Manoj, whose name is synonymous with retina everywhere. So he is going to talk to us about retinopathy of prematurity. And I don't want to say anything more. Over to Manoj for the talk. Thank you all.
Thank you, ma'am, for all those kind words. Shall I share my screen?
Yes, Manoj, it's been enabled.
Is my slide visible? Can I start?
Yes, go ahead, Manoj.
Okay. First of all, I'd like to thank Dr. Sheldon and Dr. Hari for inviting me for this meeting. It's a pleasure. It's my pleasure being a premature child myself and having gone through a lot in my early childhood. This is a topic that is very close to my heart, retinopathy of prematurity. So, retinopathy of prematurity, as we all know, is a retinal vascular disease in extremely premature neonates, which is characterized by vasoobliteration, neovascularization, and ultimately cicatrization. And it is a potentially blinding disease. Now, in India, the incidence of ROP is in the range of 38 to 51% amongst the low birth weight infants. And India has a phenomenally large number of prematurely born children annually. With advancements in neonatal care and improved infrastructure, the survival rates amongst these prematurely born neonates have improved from around 75% to around 93% recently. So this is the load of ROP that we are looking at. Now, why are we different from the rest of the world? Now, if you look at the American Academy of Pediatrics guidelines or the RC or the Royal College guidelines, if we were to screen babies with those guidelines, we would be missing around 18 to 23% of threshold ROPs. This is one of the major studies that found that gave this result. This is because our babies with ROP, they tend to be more larger, up to 2,000 grams ROP has been reported. They are more mature, up to 34 weeks of gestation. We do see babies with ROP, and even beyond 34 weeks, many of these babies, when they have other risk factors, they end up with ROP. So the spectrum of children, babies with ROP is different in our population compared to that of the West. So we need a different screening protocol, a different strategy to deal with this disease. If you look into that table, now this is a table which looks at the spectrum of AP-ROP, aggressive posterior ROP. This is a comparison of data from India with the rest of the world. Now, AP-ROP is a disease that is seen in extremely premature children and very low birth weight infants. Now, if you look at the table, you can see that our babies with AP-ROP, they are actually heavier and even older when compared to the rest of the world. So this is the difference of the spectrum in our country when compared to the rest of the world. Also, this is something that we found recently. We had published this recently. The increasing number of infertility centers across the country. Now, this seems to have increased the risk of ROP. It's an indirect risk for ROP. We found that babies born of infertility treatment end up with more ROP. They end up with more treatable form of ROP. They require more lasers, more injections. So this is something that also has to be kept in mind. Now, if you look into the embryology, we all know this. The blood vessels, they start from around the optic disc by around 16 weeks, and the nasal retina is fully vascularized by around 32 to 36 weeks. And the temporal retina takes at least 40 weeks to be fully vascularized. So this is something that we need to keep in mind. Now, when the baby, during the intrauterine period, the SpO2, especially with regard to the retinal vessels, is around 25 millimeters of mercury. Now, when the child is born, when a premature child is born, and with additional oxygen therapy that most of these children receive, what actually happens is this: the SpO2 goes up to 60 to 80 millimeters of mercury, and this hyperoxia causes cessation of blood vessels in the retina. Also, there is a decrease in VEGF and IGF-1, and all these results in the first phase of ROP. This is between 22 to 30 weeks of postmenstrual age. This is followed by the second phase, where because of this cessation of blood vessels, there is hypoxia, and this hypoxia drives increase in VEGF and IGF, and this results in neovascularization and all the other psychiatric manifestations of ROP. And this happens between 31 to 44 weeks of gestation. So the three crucial risk factors for ROP are birth weight, low birth weight. So as far as we are concerned, it is anything below 2,000 grams. Gestational age, anything less than 34 weeks, and oxygen administration. These are three crucial risk factors, but there are also a lot of other risk factors that have been identified that is listed here. Now, we all know that we classify ROP into the typical stages of ROP based on the international classification of ROP. This is the IC-ROP. The first classification came about in 1984, and in 1987 they included retinal detachment in the classification. What we commonly know is a revised classification that came out in 2005. Very recently, last year, there is an updation to the classification, and I would spend a few minutes in explaining what the new points that they have raised. So basically, we all know this. These are the three zones of the disease. We have a zone 1, zone 2, and zone 3. The zone 3 is a temporal crescent. Zone 1 is a central concentric circle, which is centered around the optic nerve. The radius is twice the distance of the optic nerve to the fovea. And then surrounding this, you have the zone 2, and the temporal crescent is zone 3. We also know that there is the ROP goes through 5 stages. This is the first stage where you see the demarcation line, which separates, which is at the border of the avascular and the vascular retina. And with time, this demarcation line becomes thicker and it increases in height, and this is referred to as demarcation ridge. This is followed by extraretinal neovascularization, which proliferates into the vitreous. This is stage 3. And later, if left untreated, this can progress to retinal detachment. This is stage 4. 4A is when the fovea is not involved, and this is 4B when the fovea is involved, so the partial detachment involving the fovea. And this is stage 5 when there is a total retinal detachment. This is plus disease. Plus disease is characterized by dilatation and tortuosity of vessels, both retinal veins as well as retinal arterioles. This is APROP, where you have disease predominantly in the zone 1 and maybe zone 2, where there is plus disease. And also you have this flat neovascularization, which is different from the stage 3 neovascularization, which is often raised. These eyes have a high risk of progressing to retinal detachment and therefore needs aggressive treatment. We also know these definitions. This is the definition put forth by the cryo-ROP study, which is a landmark study, which talked about the role of cryotherapy in the management of ROP. They define threshold ROP as a zone 1 or zone 2 disease with stage 3 and plus 5 contiguous or a total of 8 non-contiguous clock hours of involvement. So this is threshold ROP, and whenever we see such a patient, we immediately do laser photocoagulation. We also have the ET-ROP study, which is the early treatment retinopathy of prematurity study, which basically involved laser therapy instead of cryotherapy, and they classified the pre-threshold eyes into 2 groups, 2 categories. Type 1 ROP refers to the high-risk pre-threshold disease, where again laser has to be done immediately. And the other category is a type 2 ROP, which is a low threshold ROP, where a close follow-up is enough. So this is the recent, the newer classification that has come about. Now, what are the differences from the old classification? Those people who manage ROP often talk about a posterior zone 2 disease. Now, this is a portion of the zone 2, which is very critical and which is as worse as zone 1 disease. So now this definition of posterior zone 2 was very arbitrary until this new classification came out. They clearly defined what a posterior zone 2 is. This is a 2 disc diameter area around the border of zone 1. So if you have an ROP in this, then it is as worse as having a zone 1 disease and needs aggressive management. The next thing that came about was the presence of notch. The notch. So whenever we see an ROP like this, now many times we see this is the avascular area, and then you see there is a herniation or a progression of the avascularity into more posteriorly, and this is referred to as a notch. Previously, we did not know how to classify this. Now we know now the recent classification, such a notch is now, for example, in this patient, you have a zone 2 involvement, avascularity, which is now progressed to posteriorly as a notch into zone 1. So this is called as a zone 1 secondary to a notch. So we now have a better definition for these pathologies and know how to manage these pathologies. Next is plus disease. Now we all know what a plus disease is. Many times, these eyes have poor, they do not dilate well, poor dilatation. There is a lot of vitreous haze. So these are signs of plus disease. And obviously, as I said before, dilatation of both retinal arterioles as well as venules. But how is pre-plus defined? The previous classification was very arbitrary. They just said that anything less than plus disease was pre-plus. So that is always a confusion. Now we know that the recent classification has clearly defined pre-plus as either having arterial dilatation, arterial tortuosity, or venous dilatation. And the other point that the new classification talked about is the zone of involvement. Now, previously, even if you see a quadrant of involvement, we would call it a plus. Now, the newer classification gives importance to the zone 1 area. So you need to define, if you have to define plus or pre-plus, you need to define in zone 1, zone 2 area and not in any quadrant. The next term that has come new in this classification is incomplete vascularization. Often when you see these babies earlier on, you see that the vessels have not reached the periphery. There is no demarcation line or ridge. And then we did not know how to name these fundus. We used to call them as immature retina, or not sometimes even call it as no ROP presently. Now the classification group has said that now you need to call this an incomplete vascularization, because when you say no ROP, it gives a wrong meaning. So this is the term that has now come up for this. Another change in nomenclature is regarding APROP. Now, the newer classification has said that you need to call these eyes as AROP, aggressive retinopathy of prematurity, and not aggressive posterior retinopathy of prematurity, because these changes may not be just seen in the posterior pole, they can be seen even beyond. So therefore, it is now called as AROP. The older classification, this is the older classification that we are all aware of. Stage 5 disease, when you have a total retinal detachment, we would classify them as open funnel, or open narrow funnel, or a narrow open funnel, or a narrow funnel. This is based on the inlet of the funnel and the outer opening of the funnel and the inner opening of the funnel. This is again an arbitrary thing. What is open narrow for one person? Maybe open for another person. So it was again arbitrary. So the newer classification group has taken that off. They've made it very simple. 5A refers to an open funnel where you can see the optic nerve head. 5B is when you cannot see the optic nerve head. It can be a closed funnel, or it can even be a retrolental fibrovascular tissue which is obscuring the view of the optic nerve. In either situations, it is called as 5B. And 5C is when it is associated with an anterior segment pathology like cataract or secondary glaucoma. They have also defined what a regression means. Now, when you treat, when ROP naturally regresses, it also regresses following treatment. Now, how do you define a regression? The newer classification define a regression as either complete or incomplete. Incomplete when there are persistent retinal vascular abnormalities like the presence of these circumferential anastomosis. You don't see anastomosis normally. The retinal arterioles, little vessels are on vessels. And here, if you see an anastomosis, it is referred to as an incomplete regression. And often these eyes have persistent peripheral avascular area. So when you see these changes, they are called as incomplete regression as against a complete regression. Also, one needs to define if the regression is spontaneous or post-treatment. This is important because in the anti-VEGF era, when we give anti-VEGF agents, many of these eyes show excellent regression. And whenever we see a regression, generally, we stop follow-up and say the child is okay. But in the anti-VEGF era, we have realized that many of these eyes, when they regress, after some time, they come back with a vengeance. There is a recurrence. And therefore, we need to define how this regression has happened, whether it's post-treatment or whether it is spontaneous. Spontaneous regression is good. Post-treatment regression still needs to be observed. This is an example of an eye which shows regression. You see, this is the demarcation line. You can see the vessels have crossed the demarcation line. And here you can see the circumferential anastomosis. So this is a well-regressed ROP. As against this patient here you see that this is the demarcation line here. And the vessels have crossed the demarcation line into the avascular retina. But these vessels are now abnormal. Now you can see here, this is the stage 3 disease. You can see all the extraretinal proliferations here. So this is a reactivation. So when the eye initially regresses and later you see recurrence of the disease, this is called reactivation. Reactivation is a phenomenon seen mostly with anti-VEGF therapy. It is very rarely seen with laser therapy, with the good laser therapy. And also it is very rare to see when there is a spontaneous regression. So it is only seen specifically seen in those eyes which receive anti-VEGF therapy, because many of us are now trying to switch to anti-VEGF therapy. Now we also have a form of ROP which is called the hybrid form of ROP. Now here, this is described from India, from PGI Chandigarh, where there is a combination of both staged ROP, that is you may see staged ROP as well as the presence of AP ROP. There are 3 patterns that are described. This is one type where you see here, this is a ridge here, this is a staged ROP ridge here, and this is a AP ROP like picture. So the same eye having, so whenever the AP ROP eyes do not go through stages. So this is a common knowledge. But when you see both a staged ROP as well as AP ROP, the same eye, this is referred to as a ridge. As you can see in this example also, you see here the ridges here. This area is supposed to be avascular, but this patient is not undergone any treatment. You see the neovascularization has gone beyond that area. So this is a combination of AP-ROP as well as staged ROP. So this is hybrid ROP. Now this is a common differential diagnosis for ROP. This is FEVR, familial exudative retinopathy. This is these children, they do not give any prematurity history. And there's often a familial tendency, but the features are almost the same. They have peripheral avascularity, they have peripheral neovascularization, tractional retinal detachments. There is a lot of predominance of exudation also in these eyes. And these eyes, they surgically they're slightly better off than ROP. These are some of the differential diagnoses which all of us are aware of. Especially when you see a patient with retinal detachment in a neonate, we need to think of these entities which can be associated with retinal detachment. Just a glimpse into the ROP studies. As I said before, the first study was a cryo-ROP study, which talked about the role of cryotherapy in being beneficial in ROP. And this was a study group which defined threshold ROP. The ET-ROP was the next study which talked about usefulness of laser therapy. Nowadays, we don't do cryotherapy, we do laser therapy for ROP. And this study again showed that laser is very effective for stage 3 disease. But they also defined type 1 and type 2 pre-threshold disease, they said that it is also not only useful in threshold ROP, it is also useful in type 1 pre-threshold ROP. Then we had the light ROP, because we are always worried about this ambient light exposure, and the light ROP clearly showed us that a reduction in ambient light exposure did not alter the incidence of retinopathy of prematurity. The STOP ROP was a controversial study. We all know that supplemental oxygenation is a risk factor. This study found that supplemental oxygen did not cause an additional progression of pre-threshold ROP when compared to conventional ROP. Around the same time, there was another study called the HOPE ROP study, which again looked at a similar thing. But this study found that when the SpO2 is less than 94, then these eyes resulted in less threshold ROP. And then now we have the BEAT ROP and the Rainbow study. These are anti-VEGF trials in ROP, which showed that anti-VEGF is useful in at least in some situations. Now, coming to laser therapy, we all know that this is the main mode of treatment in ROP, in stage 3 disease, stage threshold disease, in pre-threshold type 1. Laser therapy is the main mode of therapy. We do laser in the avascular area up to the ridge, and then follow up the patient. Sometimes there may be inadequate regression, and you may need to add laser. So these are some fundus photographs where now you can see this is a 360-degree laser having been done. This is a stage. This is a zone 3 disease, where again laser has been done and shows good regression of all these abnormal vessels are now regressed here. So laser is a main mode of therapy. This is an APROP. So though nowadays we do not do laser, monotherapy in APROP. In olden days, not olden days, when we started off our career, we were doing aggressive lasers. So this is one such patient where you can see the laser has gone up to the border of even into the zone 1 here. And these scars are notorious for they enlarge over time, and these children have abnormal fields. Anti-VEGF therapy is something that has come up. And as I said before, the BEAT study looked at Avastin, and the Rainbow study looked at Lucentis. But recently, the neonatology, the National Neonatology Forum has come up with some guidelines as to when you should use anti-VEGF therapy. So they say that anti-VEGF is now recommended, at least in India, it is recommended for treatment of type 1 ROP involving zone 1, and it is not to be used in zone 2 ROP, because there is a high need for retreatment and other untoward effects. This is an example of a patient with APROP. In APROP, definitely there is a anti-VEGF therapy is the main mode of therapy presently. This is an eye with APROP. This is after anti-VEGF therapy. Just 2 weeks after anti-VEGF therapy, you see all the plus is resolved. It's very dramatic. In 2 weeks now, you see the vessels have all the shunts have gone away, and there's better vascularization. And this is almost at 1 month, showing a near normal retina. But the problem with the anti-VEGF therapy is that it is not always self-sustaining. Often you have recurrences, and these recurrences happen pretty late. So that is the problem, because when we follow patients with ROP, there is a period, there is an exit criteria. Generally, we would follow up a baby for a period of around 44 to 45 weeks gestation. That's till that time we generally follow babies with ROP. And if the baby does not have any significant ROP at that time, or has got adequate regression, we would actually take the child out of follow-up. Now, when a patient is on anti-VEGF therapy, it is a very dangerous thing to do, because studies have shown that as late as 65 to 70 weeks, the neovascularization can recur in these patients. And therefore, one needs to examine these children, babies, for a much longer time. And this is the recommendation of the National Neonatology Forum. So in practice, it's very difficult. So in practice, what we end up doing is to add laser by around 40 to 44 weeks. If there is inadequate, if there is persistent avascularity, we would do additional laser photocoagulation of these eyes, and therefore we can take these children out of follow-up early. Endophthalmitis is also one of the dreaded complications following anti-VEGF. Most of these eyes are bilateral, and sometimes if you can end up with a bilateral endophthalmitis. Coming to surgical indications, I'll just make a passing mention. Scleral buckling, vitrectomy, both lens sparing and lensectomy vitrectomy is a mode of therapy, surgical treatment. Now, when you have a stage 4A ROP, that is when there's a retinal detachment not involving the fovea, scleral buckling is useful. But when you have the fovea being involved, that is stage 4B ROP, then you need to do a vitrectomy. Often it is a lens sparing vitrectomy that we do these days, but sometimes, especially in a stage 5 ROP, or when you have a lot of retrolental fibrovascular tissue, you may need to sacrifice the lens as well. These are some spectacular results from a colleague at Coimbatore. So these are all 4B eyes which have done spectacularly well, but generally the surgical results are poor. In 4A, the anatomical success is around 50%. In 4B, it is between 30 to 50%, and in stage 5, it is less than 20%. This is just the anatomical results. If we talk about the functional results, it may be even less than that. One needs to follow these babies for a long time. Follow-up is very essential because late surprises are very common. Many times these are missed, but these are very common. You could have late peripheral retinal detachment, retinoschisis. You could have a lot of vascular anomalies like abnormal neovascularization, and therefore the American Academy of Pediatrics now recommends performing an angiography in these children. When you follow these children, they say that you need to do an angiography at some point of time, because angiography helps us to identify those persistent avascular areas, can pick up new vessels, and if you treat them at the right time, you can prevent untoward events. So these children generally have unhealthy retinas for life, and they require periodic follow-up. Now, the last part of my talk is on this very important topic. Are we geared to take up this challenge? These are some of the questions that I would like to pose to you. Do we have the required personnel for primary screening? Do we have a foolproof program of screening, and do we have the adequate mechanism for follow-up? Often, the answer is no. So this is a sad part. We have very good clinical guidelines. The National Neonatology Forum has given us some very good guidelines as to how to screen and manage ROP. Now, whom should you screen? Now, this is the take-home message. Whom should you screen? You should screen all babies born at less than 34 weeks of gestation. Any baby where the gestation at birth is not known, you should consider screening these babies early. When the birth weight is below 2,000 grams, you need to screen these babies. If the baby is between 34 to 36 weeks, but has the following risk factors, there is a need for respiratory support or oxygen therapy, there are episodes of apnea, or there is a need for blood transfusion or exchange transfusion, then you need to screen these babies. When should the screening be done? If the baby is less than 28 weeks, and especially if it is less than 1,200 grams, the first screening should be done as early as 2 weeks of age. APROP is very high in this group. We need to pick this up at the right time. If the babies are more than 28 weeks at birth, then the screening should be performed not later than 4 weeks. What drops should be used? This is again well defined by the NNF guidelines: 2.5% phenylephrine and 0.5 to 1% tropicamide. We have combination drops available. You just need to put 2 drops, 30 minutes. They get adequately dilated. If it's not dilated, be worried. You're probably dealing with APROP. Alternatively, you can just use tropicamide. It's better to avoid phenylephrine because there are a lot of systemic toxicity with the drug. Topical paracaine is enough in these eyes, and just to make the child comfortable. They advocate, especially the Neonatology Forum, they advocate oral 24% sucrose or 25% dextrose to these babies when being examined. Now, regarding how should you do the examination? Now, we all know that indirect ophthalmoscopy is a gold standard. There's no denying that. But often when there is a lack of trained personnel, one could use retinal photography, the wide angle digital retinal camera, because it's a very easy instrument to use. And in fact, the National Neonatology Forum guidelines says that this should be encouraged, even if you have an ophthalmology-based screening. This is for better documentation and medical legal purposes. Now, when should you terminate screening? So whenever there is complete vascularization of the retina without any ROP features, then the screening can be terminated. If the ROP has shown complete regression, this usually, as I said before, it happens between 40 to 44 weeks. But if the child is on anti-VEGF therapy, you need to follow up these children for a longer time. Now, how best to bridge this gap? So this is something that I have learned from my colleagues working on ROP. Now we have a lot of babies. The problem is more, and we have less expert care providers. So the best way to deal with this problem is by training our paramedical staff, the NICU staff, for example, for screening. You could also use teleconsultation. So this is something that we have been trying to do. We have been trying to incorporate retinal imaging into ROP screening. This is an excellent equipment that we have been using since 2017. RedCam is a 130-degree wide-angle contact pediatric retinal imaging system. There is a short video. Let's see if it works. On how we have tried to train our optometrists to do screening, and we run this project called Cradle ROP. This is spread over 5 districts in Kerala, where our optometrists, they go with this camera, they take these photographs. The photographs are beamed to us, using WhatsApp, and then we can actually make a comment on this. When the neonatologist is standing there, so we can interact with him, and they do the talking along with the optometrist, and this is what we have been doing.
Cradle ROP stands for Chaitanya RedCam aided digital screening, laser treatment, and empowerment of ROP care. When the team arrives at the screening center, which is the NICU, the neonates are kept dilated and ready by the NICU team. Data regarding the gestational age, birth weight, and other neonatal risk factors such as oxygen supplementation, mechanical ventilation, etc. will be recorded and captured on software. Then the babies will be subjected to fundus photography with RedCam shuttle camera. Topical anesthesia will be used and the eyelids will be kept apart during the procedure with a speculum. The photographs will be taken by ophthalmologists trained in ROP care or by certified and trained technicians. Typically, 6 images are obtained using the 130-degree ROP lens and include macula-centered, disc-centered, temporal, superior, nasal, and inferior quadrant images. All along, the baby will be monitored by the neonatologist or the NICU team for bradycardia and apneic spells. After the procedure, topical antibiotics are instilled and the baby handed over to the parents. The whole procedure of screening is over in 5 to 10 minutes. The findings are recorded into a data sheet and in the NICU file. The ROP caregiver also explains the disease condition to the parents. Another unique part of this screening process is the possibility of sending the images via the internet to an ROP expert in situations where a second opinion is required. Here, the image taken by the trained technician is being transferred to the ROP expert using the commonly available WhatsApp application. Within minutes, the expert will get the images on his smartphone. The image obtained thus is fairly reliable and the expert can give his opinion. The future of ROP care probably lies in these simple innovations.
So this is the work that we have been doing since 2017. We are associated with around 18 centers across these 5 districts of Kerala. We would love to call them as passionate centers because they are as passionate as we are in managing ROP. So this is the schedule that we have. We have a tight schedule, and there are days when we go to each place. And on Saturdays, we do all the data compilation and review. We have had some publications also from the data. We have screened around 3,065 eyes till now, around 7,217 sections, 129 lasers, 12 injections. We have seen 6 ROPs. We have also seen 2 hybrid ROPs. So this is the data that we would like to share. And this is just 2 slides on our experience. Now, initially, we had this apprehension. How would the people take up photography by an optometrist? How would they respond to it? Now, we did a comparison. Initially, we did a comparison with indirect ophthalmoscopy versus photography, and we found that we did not miss any treatable ROP. It was less traumatizing to the babies. In fact, the incidence of bradycardia and apneic spells was much less with the RETCAM screening when compared to indirect ophthalmoscopy. And the neonatologists and parents, they were extremely happy. And parents now are extremely happy because we could show them photographs. We could convince them that, okay, this is where it is bleeding. Or after laser, we could convince them that, okay, the bleed is now gone away. We could cover more area. We could travel 270 kilometers a day, multiple centers, because we could use our optometrists for all of that. The learning curve is also very short. For an ophthalmologist, to learn indirect ophthalmoscopy, to learn ROP care, not difficult. But if he learns to adopt a RETCAM screening, he can just learn 15 days. And even for the optometrist, by around 1.5 months, he would actually learn to interpret these images. Teleconsultation is possible. And even when I have a doubt, I can send images I send it to Coimbatore Parag, my colleague, my junior, whom I have convinced him. He is part of the international classification group. I'm very happy that he is part of the group. So I send images to him, and he would give his comments. Again, from the medical legal aspect of, you could record response to treatment, you can document recurrences. So RETCAM is something that is there to stay. There is a growing evidence of teleconsultancy all over the world. There are large projects which are running, the SunDrop, the eDrop, and now in India we have a very successful program, the KidDrop project, which is entirely non-physician based screening and hugely successful. So to conclude, our understanding of ROP has increased over the years, and we know that ROP blindness is preventable with optimal screening and treatment. But the increasing number of premature babies at risk and the relative lack of trained ROP experts, is driving the transition to retinal imaging and remote screening. I think this is the future of ROP care. Thank you.
Thank you, Dr. Manoj, for the excellent, informative talk. And it is very useful to each and everyone, the new classification and the management, and especially the cradle ROP part. And now I think you can, if there is any question from the audience, we can ask Dr. Manoj.
Days we used to talk about a myopic shift that used to occur after lasers. Does that occur after anti-VEGF also?
No, it does not happen. So at least the data does not seem to denote that. It's mostly with the laser eyes. Laser, because there's a lot of choroidal degeneration that happens in the lasers. There is some kind of an ectasia that happens there that contributes to the increase in axial length. And therefore now my shift towards myopia is not something that is described in anti-VEGF injections. But I think the data also is not enough because now we have been recently only doing anti-VEGF, so we do not have large data. But at least the data from the BEAT study and some of this follow-up data from those trials have shown that it is not very significant.
Myopia is more common refractive error in these people. That's what we see.
Prematurity itself is a risk factor for myopia. So so in that sense, now we would see more myopia in these babies.
Children are also sometimes with brain anomalies also, they don't cooperate for vision testing. That's what we find. All these people from Kim's, Dr. Naveen sends for ROP checkup and all. And afterwards, from 1 to 5 years, we have to follow up. It's very difficult sometimes. They don't cooperate. They don't see anything. So we have so much of difficulty in prescribing glasses. All we do retinoscopy and try our best usually. Okay. If there are no more questions, I think we will go to the next talk. Thank you, Dr. Manoj. Manoj, you'll stay till the end now. Okay.
I will.
Okay. Okay, thank you. So the next talk is by Dr. Anitha Unni. She's a multifaceted personality, very expert in dancing as well as in clinical work and skin correction, oculoplasty, everything. So let us hear about amblyopia from her. Over to Dr. Anitha.
Thank you very much, ma'am, for your kind words. Just wanted to make sure, is my screen clear and...
Yes, we are a little scared.
So at the outset, I really wish to thank all the organizers, because it's really a great honor for me to give this talk of a CME by Karakoram Medical College. And also it's an extreme pleasure for me to see all our dearest makkal, my dear PGs, I would call them, as really, really happy to be with all of you. So this particular topic, I would like to start with a small clinical scenario. Could all PGs just have a look at this 19-year-old young, energetic, enthusiastic boy walked into my room asking for a driving license certificate. And as you can see in this, the right eye vision is 6/6 and left eye is only 6/36, which the best corrected visual acuity is only 6/18, because the child, the boy has a refractive error. And as you can see here, all other examination findings are within normal limits. So what could be the diagnosis? Anyone, please?
Anisometropic amblyopia.
Very good. Exactly. Very good. Excellent, Aina. So this is a case of anisometropic amblyopia, right? So just one, the young boy, I should say, was quite shocked to know at that point. He came to know only then that his vision is not equal in both eyes, and he was not able to see well because he had never had an opportunity to close one eye and check his visual acuity. Okay, so but he seemed quite shocked and upset, and I told him, doesn't matter, I can give you still fit into the criteria, I can still give you the driving license fitness form. But then he still seemed to be upset. So I asked him what is the reason. He said he was dreaming of joining some time ago while I was doing my PG days or something like that. I would have told him there's not much we can do about it. We can do the amblyopia treatment only till about 12 years. So we could sorry, is my internet connection unstable? Is it okay?
Now it's fine, Anitha. Now we are able to hear.
Okay. I don't know. My Zoom, I mean, my internet is all charged up and all, but I don't know, because of the rain, I don't know. Anyway, so then had it been few years ago, we would have told them, I would have told him that no, it's not possible. It's only possible only till the age of 12 years. But now, since there is much more understanding about the concepts of neuroplasticity, about the concepts of mechanism of amblyopia, about the interocular suppression, and about the various aspects of binocular treatment, dichoptic treatment, the horizon of treatment of amblyopia has widened a lot, and we have every opportunity to try amblyopia treatment in every individual who walks in. So let's see how we go about this topic. Okay, so as this is a talk predominantly for the PGs, just like writing an essay, it was always better to divide your a topic into these subheadings so that you don't miss any particular point. Okay, so first of all, what is amblyopia? According in the Greek language, it means dull vision. Basically, it is a unilateral or sometimes bilateral reduction in visual by best corrected visual acuity. That is, in between the two eyes, a difference of 2 lines, or if binocularly, a visual acuity less than 6/9, which occurs in an otherwise normal eye or in an eye with structural abnormality. You see there's some anatomical or a substructural abnormality, but that is not the sole responsible feature or sole responsible cause for the diminished vision. Because the visual acuity does not improve even after the treatment of the root cause. So that is known as amblyopia. Now, why should we know about the epidemiology of any subject? Because it helps us in identifying the gravity of the situation. See, when we know that in India, about 1 to 4% among 100 people is suffering from a condition which, if appropriately addressed and treated or prevented, it could prevent a cause of lifelong, profound, permanent visual disability. So we know that this is a condition which is of quite a significance to be talked of, right? And it is one of the most common cause of decreased vision in children as well. We also need to know that prematurity, developmental delay, and maternal substance abuse are all causes of increased incidence of amblyopia. And knowing the pathophysiology always helps us understand the condition better, and therefore we can formulate better modes of treatment for the same. Hugel and Wiesel explain that visual system is not fully developed at birth. Vision is a learned process. The eye is in stages of several dramatic stages of developmental plasticity, and during these stages, it needs both unilateral and bilateral normal visual experiences so as to have a proper anatomical and functional organization. They also put forward a terminology called critical period, that is a few weeks after birth up to even 9 years of age, where the eye is highly sensitive to any abnormal visual stimuli. Like there is a light deprivation, like in what happens in cataract or the conditions alike, or there's a form deprivation which happens in uncorrected refractive errors, or there's some abnormal binocular interaction, like what happens in strabismus or squint. What happens? There is a defective spatial visual processing which is happening in the visual pathway. That is where the importance. Before, we used to think that the lazy eye or the amblyopia is confined to the eyes, but no, the amblyopia is actually, the defect is happening in the visual pathway, and there is some poor transmission from the fovea to the striate cortex. Although we say that there is no structural abnormality, we said otherwise normal eye, right? But now with the advent of OCT and several other methods, it has been identified that the fovea is thicker because of the poor migration of the ganglion cells. And we find that lateral geniculate bodies and the striate cortical fibers are shrunken in case of amblyopia. Also, this picture from Adler very clearly shows that there is a reduction or suppression of binocularly driven ocular dominance columns in cases of amblyopic children. So we need to redefine amblyopia. So it is a developmental cortical disorder. So we now understand that amblyopia is a cortical disorder. It's a developmental disorder which is caused by abnormal visual stimuli which reaches the binocular cortical cells in the early stage of life. That is the sensitive period. That is a critical, in the critical stage of life, that is the early from birth till 9 years of age. If there are abnormal visual stimuli reaching the binocular cortical cells, that results in a cortical disorder, which is otherwise known as amblyopia. Therefore, amblyopia is not lazy eyes, it's lazy brain. Now, we all know about the various classification of amblyopia. Just like I tell PGs always, the mnemonic to all remember easily is S2A2, strabismic stimulus deprivation, and anisometropic and emetropic. Of course, meridional can also be considered as a type of emetropic. And there is always a mixed type where more than one reason is there for to attribute the cause of amblyopia. Talking about strabismic amblyopia, it accounts to the most common type of amblyopia. About 50 to 80% cases are strabismic amblyopia. But the good thing about it is that this is the most amenable to treatment. One thing, the reason for amblyopia here is the constant defocused image, which is coming from the extrafoveal fixating point of the squinted eye, the eye which is not aligned. Also, there's one more reason, that there is always a possibility of overlapping or superimposed images, diplopia, which also makes the eye to the brain to ignore that image from the eye which is not aligned. Therefore, this is all seen only in case of unilateral squints. So we have to know that in alternating fixating squints, we never find amblyopia. Also, this happens only in constant squint. So intermittent squint, we don't see amblyopia because there is no constant defocused image there. Okay, there is some clear images coming in between. Therefore, never happens in intermittent, never happens in alternating squint. One more thing to note is that esotropia is more amblyogenic than exotropia. And as I have mentioned here, there is no correlation with angle of deviation. Can anyone say the reason why I'm saying this? Any PGs? As you know, when we look at the causes of amblyopia, we need to think of microtropia, right? Microtropia is just less than 5 degrees of prism diopters of less than 5 prism diopters is enough for causing amblyopia. So that is why we say there's no correlation with the angle of deviation. The next common type is the anisometropic amblyopia, where you have difference in the two difference between the power of the two eyes, right? There's an unequal refractive error. So there's a constant defocus of image from one retina. Here, just like what we saw the first clinical scenario where the boy came with the driving license certificate, unless a child closes one eye and checks, they never get an opportunity to identify. And therefore, this is always missed and they come to know of it only later in life. Therefore, the importance of preschool screening in order to identify the anisometropic amblyopia. One more point I want to highlight is astigmatism is the most amblyogenic, and the difference of even 1.25 diopter of astigmatism is enough to cause amblyopia. And the next is hypermetropia. Children can tolerate a difference of 4 diopter of a difference between the two eyes in order to maintain good vision without developing amblyopia. The most damaging, the most resistant to treatment is the stimulus deprivation amblyopia, but very fortunately, this is the least common of the lot. What all are the causes? Monocular congenital or traumatic cataract, even binocular cataract for that matter, complete ptosis, corneal opacities due to any reason, including glaucoma, all the causes of corneal opacities, even occlusion amblyopia, that is the prolonged patching of a normal eye for any reason, is also it comes under stimulus deprivation amblyopia. So this is the most resistant one, but it's the least common category. Isometropic amblyopia, where you find that bilaterally there is high refractive error always, but still there is amblyopia. So bilaterally it is equal, very much equal. There is no anisometropia, but still there is amblyopia. And for these conditions, the myopia should be more than 10 diopters, hypermetropia 5, and astigmatism even more than 2 is enough to cause amblyopia in both eyes. Meridional amblyopia, again the same. Astigmatism uncorrected will always result in defocused images both for near and for distance, and that is the reason why astigmatism is more prone to more amblyogenic. And mixed amblyopia, many situations we find that it's not only one. It's like in case of strabismus can be associated with a refractive error and so on, where more than one mechanism is involved. How do we go about it? We take a very detailed history about prematurity, about birth weight, about any previous treatment of amblyopia, about any usage of glasses in the previous, all the detailed history we need to have. And then according to the age appropriate method, we need to measure the visual acuity. We have to look at the pupils, we have to look at the red reflex and make sure that there is no media opacity. The fixation pattern in small children, we look at the fixation pattern. If it is not central, if it is not steady, if it is not maintained, we need to think of possibility of amblyopia. And in those who can do a cover test, if there is a fixation preference for one eye, we should identify that there is a possibility of amblyopia. Then next is to check for binocular single vision, visual acuity. That is Words 4-dot test, Bagolini striated glasses, and the test for stereopsis, that is TNO test. Ideally, these stereo acuity tests have to be done prior to doing a cover test. That is, before the eye is dissociated, we have to do the test for binocularity. And to detect if there is any squint, we can look for Hirschberg reflexes, we can do the cover test, and abnormal head position always gives us a clue. A detailed slit lamp examination to identify any anterior segment pathology, a cyclorefraction, and a thorough fundus examination to rule out any retinal diseases will always help us to cling to the diagnosis of amblyopia. Amblyopia not only affects the visual acuity, it also affects the contrast sensitivity, stereo acuity, and the whole similar other aspects of vision as well. But two important aspects we need to mention is a very typical of amblyopia, or very specific to amblyopia, is neutral density filter and crowding phenomena. In neutral density filters, by increasing by changing the neutral density filter in front of the eye, we actually reduce the luminance without compromising the color. And we see that in normal individuals or persons with normal vision, the visual acuity actually reduces. But in case of amblyopia, the visual acuity remains the same, even if the luminance is reduced. Why does that happen? It's because in the usually in cases of amblyopia, especially in those cases where there's an extrafoveal fixation, there are more cones in that area. So because of this reason, it is the extrafoveal point which is stimulated. That is the reason why there is no decrease in visual acuity in amblyopic people when they look through neutral density filters. The next one emphasizes the importance of checking the line visual acuity rather than single optotype. So when we check visual acuity, when we ask them to read in single optotype, they can easily identify. But when we ask them to read in a line, it is difficult for them. So that is what is known as crowding phenomena. And the same effect can be obtained by putting bars around the single letters. So that also gives the effect of crowding phenomena. So easier to measure and to confirm the diagnosis of amblyopia. Okay, now the next and the most important part of my talk is about management, right? So prevention, as we all know, is early prevention, that is by screening and early detection, is the mainstay of treatment, of management of amblyopia, because it's always difficult to treat. If we identify early and prevent it, it's much more easier. And just by looking at the Bruckner reflex in case of red reflex in newborn, we can identify media opacities, and even amblyopic red reflexes by Bruckner's test will the eye will be more brighter and lighter. We can identify that this eye has a possibility of amblyopia. American Academy of Pediatrics actually suggests to start screening at 1 year. AAO recommendation is to start at 3 years and then to repeat and then to follow up every 2 years. But in any child with any predisposing factors like developmental delay or any premature child, detailed examination has to be done. Now, there are lots of studies which were undertaken, which comes under the series of amblyopia treatment studies, that is Pediatric Eye Disease Investigation Group. Starting from ATS 1 until now, there are ATS 19 which is going on currently, where they try to identify whether patching is better or atropine is better, or whether full-time patching or weekend patching, number of hours of patching, and whether near work is better or far work is better for better treatment, or whether there is any whether how much effective the newer modalities is. And presently there's one study which is saying whether the refractive surgeries, the role of refractive surgeries in the treatment of amblyopia. So according to those studies, let us just try to evaluate the management protocols. We should go in a stepwise approach. The first one being eliminate the cause for visual obscuration. And then the next one is to give appropriate refractive error correction. And then even then, if there is amblyopia, we have to force the use of the weaker eye by limiting the use of the normal eye. So eliminating the cause, as we all know, if there's a congenital cataract, we have to get it removed as early as possible. If it is by about 4 to 6 weeks of age, as soon as the child is able to withstand a general anesthesia. In bilateral cases, always remember to do the second case without any delay, with a maximum of 2 weeks or 3 weeks immediately after the first case. We have first eye, we need to post the second eye. And one very important aspect is to give appropriate post-op refractive correction and motivate the parents to do a meticulous amblyopia treatment. Because even yesterday, I had a 25-year-old gentleman coming to my OPD who has undergone a beautiful congenital cataract surgery at the age of 2.5 years. He developed posterior capsular opacification, which was removed at the age of 7 years, but he was not motivated enough. I won't say that he was not told about amblyopia treatment. The parents were not motivated enough to give a proper glasses and to have a patching of the other eye. So when we see such cases, we feel really sad because of a beautiful cataract surgery done. The surgeon has done a great job, but the man comes with a counting finger, not improving with even a pinhole vision to us. So that is something which we all need to think about, and we all need to address as soon as we see such cases. And strabismus correction, one point to mention is that it is always better to do a strabismus surgery after equalizing vision or after the amblyopia is corrected, when we have to make sure that there is an equal fixation or equal visual acuity before we go ahead with strabismus surgery. This is for two reasons. One thing is uncorrected, like if the eye is continuing to be amblyopic, there is always a chance for recurrence of the squint. Or also one more reason is, as soon as the eye becomes straight, the parents become less motivated to continue the amblyopia treatment. And also prompt treatment of other mediopacities like any causes of corneal opacities, glaucoma, ptosis, etc. has to be done before going on to the next stage of management of amblyopia. The recent study about the refractive surgeries in the management, that is the studies which are, the study usually, now it is talking about PRK in those children who are non-compliant with glasses, who have some neurobehavioral disorder and a severe anisometropia. In those patients, whether we can do a PRK, that would help in that would help in the better outcome of amblyopia treatment, is a current study of ATS. Now, the second one is the correction of refractive error. Proper refractive correction itself is all by itself is enough to correct to improve amblyopia in 77% of cases and completely treat amblyopia in about 27% of cases. So whenever a child comes and we find that the vision is not, the best corrected visual acuity is not 6/6, we don't start glasses and amblyopia treatment together. We need to wait for few months, at least for 4 weeks to 3 months, 1 to 3 months, because let the child get used to the glasses first, and then we incorporate the amblyopia treatment of occlusion or penalization or whatever. But there's one more reason. Sometimes these children just improve just with glasses. So we may not even need to start an amblyopia treatment. So that is also important. Now coming to how to make the normal eye, how to limit the use of normal eye and how to stimulate the use of the amblyopic eye. There are, the penalization is not what everyone knows about. Penalization can be for near or for distance or total penalization. Like in case of atropine, we are actually penalizing the normal eye to do the, for near, whereas optical penalization, we are giving a high plus so that, the normal eye cannot see for distance. And in occlusion, we are actually preventing both the near and the distant vision to the normal eye and using and forcing the brain to use the amblyopic eye. It would be strange to know that there is some penalization methods were tried as early as even 600 AD. And as we can see here, the children are given a mask. Children with esotropia are given a mask where only the mouth is open, and the binasally there is a cover which which actually patches binasally, and this is found to have some role in treatment of esotropia. Okay, so the various of all the modalities of treatment of amblyopia, occlusion still remains as a gold standard, still as a very effective treatment, because the success rate comes to about 30 to 92% cases according to the motivation and the compliance. So here we are preventing the sound eye from fixation. And one more thing to note is that as we know about the pathophysiology, as we know more about the pathophysiology of amblyopia, we realize that there is some inhibitory stimulus from the sound eye to the amblyopic eye, and this is removed by patching. So that is how it really helps in improving the amblyopia, improving the development of the visual pathway. There are various types of occluders available, but the one I always prefer is the one on the skin on patch, because it completely prevents the sound eye from focusing for near or for distance. And even so that is one thing I always prefer. And one more thing is there are many occluders now available, even opaque contact lenses are even available for occlusion, which can be tried in elder children or adults. And next question is, how much patching? According to the ATS, for moderate amblyopia, that is if vision is better than 6/36, up to 2 hours of patching is enough. It will do an equal effect of 6 hours of patching. And if the amblyopia is severe, that is from visual acuity is less than 6/36, we find that 6 hours of patching does an equally good job as a full-time patching. Therefore, there was a protocol for a full-time patching, which is still undertaken in selected cases according to the age of the child, number of days patched, and the one day the rest of the, according to the schedule, there will be number of days the sound eyes will be patched, and one day the amblyopic eye will be patched in order to prevent occlusion amblyopia. One point to note is that as we were mentioning about the improvement, older children will improve only if it was found in one of the amblyopia treatments trials that older children will improve only if they were not previously treated. And all of you, especially postgraduates, will please, you at one point or the other, you will have to explain occlusion therapy to children who are coming with amblyopia. And I would suggest you, please tell them not to just wear the patch and go around and play outside. You will have more effect when the children do active vision exercises. Simple things like, joining dots, coloring, tracing, threading beads, or, embroidery if they are girls, and tell them to read comics. And, I usually tell them to take 4 sheets of newspaper and circle one alphabet on that newspaper every day. Or you can do dotting O's, like put a dot, or you can take a tray of rice, wheat, mustard, and different grains, and then ask them to segregate with one eye closed. So all these intricate works will really help them to give active vision exercises and therefore stimulate the pathway. And how long should you continue? Usually they say up to 6 months or 400 hours of patching until the visual acuity becomes equal, or there is an equal fixation, or if full-time patching and there's no improvement, we can stop patching. But always we need to reassess our clinical findings, make sure that we are not missing any anterior segment or posterior segment caused for amblyopia. It is very, very important to follow up children every month, or depending on the various age groups, because we need to check for visual acuity, we need to check for the fixation, make sure they are not developing an occlusion amblyopia. And one more thing, the reason why we need to see them is they lose their motivation, they slowly stop patching. We need to keep them motivated. And once the vision is equalized and they reach 6/6, if they stop patching once immediately, just like steroids, we see that there is possibility of recurrence, even up to 25%. So we need to tell them to gradually taper. We can reduce the number of hours or change the total patching to partial patching, etc. the disadvantages of patching, as all of us know, is occlusion amblyopia. Non-compliance is the most important thing, because these school-going children undergo the psychological stress and skin rashes, cosmesis. And one thing is patching sometimes will make will decompensate and make an intermittent exotropia or intermittent squint to become a constant deviation, or is difficult in children with latent nystagmus as well. So then comes the role. Next, most commonly used type of penalization is the use of cycloplegics, atropine, where the advantages of being better compliance and can be used in case of intermittent squint, as we said now. Sometimes can be used as a maintenance after occlusion, and it's very effective in anisometropic amblyopia, especially if the non-amblyopic eye is hyperope. And one of the amblyopia treatment study found out that weekend atropine is equally effective. So it's very easy for parents to just apply a drop during the weekend, and it would give the it is found to have very effective. But the disadvantages of applying a drop includes the side effects due to systemic absorption and the risk of occlusion amblyopia, where if at all we notice that a child is developing occlusion amblyopia, we can just easily reverse it by asking them not to patch, but whereas this will take few days for reversal. So it is also not suitable in severe amblyopia, because the amblyopic, the sound eye visual acuity has to be made lesser than the amblyopic eye to have any effect. So that is the reason why. And one of the amblyopia treatment studies have shown that a patching is almost as equal as atropine application. Therefore, we could choose either of the two, and many choose to have occlusion rather than going for a atropine installation. One of the yet another studied drug is levodopa or carbidopa, where it actually is found to it targets on the neuroplasticity. It extends the sensitive periods, and it reactivates the neural pathways, the visual pathways, and therefore improves the amblyopia. But one of the study, and it was actually used as an adjunct to patching, and a study was performed where they showed that it was not much, it didn't have any added benefit when compared to patching alone. And some other neuromodulators like citicoline, which is a catecholamine based drug, and selective serotonin reuptake inhibitors like citalopram, and cholinesterase inhibitor like donepezil are all various newer pharmacological therapies which have been tried in amblyopia. Some methods which were used in the past were CAM visual stimulator and pleoptics. I'm mentioning this, these are of historical importance only, but I'm just mentioning this just in case anybody wish to, any examiner would like to ask the PG students. So I just put a slide where CAM visual stimulator has some high contrast grating, square wave grating, which is slowly rotated to stimulate the amblyopic eye. And in pleoptics, what is done is all the peripheral retina is dazzled by an intense light, and only the fovea is protected, and after that the fovea is stimulated. So that is how it works. Just the last part of my talk is the most important, that is the recent advances, where lots of newer therapies, especially the most important among them is the binocular or the dichoptic therapy, where as I said, the concept of amblyopia is different now. They say that only occlusion of one eye is not enough. We need to improve the binocular vision, give binocular stimulus, and make the interaction, need to integrate or interact both eyes, so that the better visual outcome is obtained. So one of them is vision therapy, which can be done as an adjunct to occlusion, where accommodation and anti-suppression activities can be, the child can be made to practice this either office-based or home-based. And next is a perceptual learning, where repeated visual discrimination tasks like stereo acuity, position sense, etc. are done. Some kind of exercises are done 2 hours per day and 5 days a week for 9 months. They have been found to improve the amblyopia, especially in adults. This is the latest or the newest, which is a method which is found to be very, very effective. That is binocular or dichoptic therapy, where the independent images are presented dichoptically to the both eyes, and it's supposed to overcome suppression, because anaglyphic glasses are given These are all available in the internet. Main two games which comes under this category are the falling block game and the dig rush game, where high contrast red images are given to the amblyopic eye, and the low contrast blue images are given to the fellow eye, and some objects like rocks which are gray are seen by both. So they need to integrate these images and play the game. So when it is about game playing, everybody, be it irrespective of child or adult, everyone is interested in playing games, so they can concentrate more, and they can actually follow a low contrast image more because they want to win the game. So we get the person gets more motivated, and therefore the results are much better as well. These methods also incorporate the same method or same principle of binocular stimulation, where there is a monocular fixation in binocular field. Then there are liquid crystal display glasses, where each glass will become opaque and clear alternatively. So there's an intermittent occlusion is obtained by that. And there is something called virtual reality head mounted display, where interocular suppression elimination is the principle. So action video games have been found to have highly effective very high effect in the management of amblyopia, where the brain plasticity is addressed, and it's very, very effective. And there are some programs which are available, like interactive binocular training, iBit and AMP iNet programs, which can be done once weekly for 6 weeks and all, where you find where the adults have found to have improved visual acuity. So the concept of adult amblyopia was realized when people of even older people, when they lost their good eye due to some reason, they found that there was some visual improvement in the supposedly amblyopic eye. So that is how the concept of adult amblyopia treatment came in, and the better understanding of the fact that the neural plasticity of the visual pathway, it very well extended beyond the critical period. It is not the abnormal visual stimuli during the critical period causes amblyopia, but the neuroplasticity is not limited to that period. It is extending throughout life. Therefore, adult amblyopia has to be treated. There are many online programs available. If we check in the internet, we can purchase many of them. Some are even, we need not even purchase, we can just play. Some needs to be downloaded and all. So one such program is a Revital Vision. It's an online program for 3 months of 40 training sessions of 30 minutes each. I'm just mentioning this just in case anybody asks you, no financial interest whatsoever, just to, to guide some persons who may ask you. One small interesting finding which was noted was that adults who were doing the transient eye patching while watching a movie, and they were doing a stationary by cycling, they found that the physical activity actually helped in, they had better results than those who did not do a physical activity. So we have to understand that the main challenge in the management of amblyopia is compliance, and motivation is the key. The younger the child, the better prognosis, and the number of hours to be patched is much lesser in a younger child. And myopic anisometropia has a better prognosis than hypermetropic anisometropia, which has a better prognosis than strabismic. And as I said, stimulus deprivation is the the most resistant to treatment, and many other factors like eccentric fixation, age of the child, age of the person when we are starting the amblyopia treatment, whether there was any previous amblyopia treatment done, type of occluders, the compliance, and so many factors are important in the outcome. And of all, I think the gold standard is still occlusion and penalization, but with the advent of the newer treatment modalities like binocular treatment and pharmacomodulation, they do appear promising, and lots of studies are underway, but still the results are awaited. So once again, thanking you all very much for the patient listening. It was slightly a longer topic than was expected, so I had to rush through, but I hope things were clear, and we could have some question answer session now probably. Thank you very much.
Thank you, Anitha. It was very excellent talk and very informative. You have covered almost everything. Nothing else to add. But years back, the first person you told now came for driving license. if we had seen him, you would have told nothing can be done. That
Yes,
now
ma'am.
you have covered 10 years of age, we cannot bring back the vision and all. But
Yes.
there is some light at the end of the tunnel now. We can just proceed with amblyopia therapy even in 60-year-old person
Yes.
or above that probably, and we can improve something. This is something which in my experience also I have seen the vision improves up to 618 at least. Up to
Yeah.
618 I have improved in adults and elderly people also. Not very elderly, 30 years like that. But beyond that, there was not much of improvement. I don't know about anything much about that. So that is what we see. At least that much of improvement you can give, by therapy and all. In childhood, as you notice, the parents, and even though both of the parents are working, we ask for the occlusion and all. The child will remove it because the grandmother is looking after the child. Nothing happens in some cases, and we find it very difficult sometimes. Anyway, it was a very nice talk. You have covered all the points about amblyopia. We are very happy.
Thank you very
So,
much.
any questions from the audience?
Good evening, Susila madam.
Oh, very nice.
So,
I think we are the constant people everywhere.
yes. So, and good evening and thanks to Sheldon and Jasmine.
Good evening. Thank you for coming online.
So, Madam Susila madam, I find that these evening CMAs, we tend to assimilate more than the CMAs which we go and sit in the morning. And I think in a relaxed atmosphere of home, probably the digestion and assimilation is a bit more better. That is what I feel.
You mean towards the evening we can take more into the brain? Is it like that?
So yes, madam. So we have Manoj. We always hear. Yeah, Manoj always hear in a lot of fora. But anytime Manoj speaks, we get 2 or 3 points. And actually, I didn't know the recent ICROP classification 2021, and that was a new thing I heard from Manoj during this evening. Thank you, Manoj.
Thank you.
So and Anitha, I think I have heard her maybe some time back, but I am hearing her more this evening, and I find that she's a very good teacher.
Thank you very much. Thank you.
And
she is a very good teacher.
Yes, she's a very good teacher. And as she said, no, amblyopia probably Susila madam may remember maybe 2 decades back. Then again we used to do this occlusion, but the problem is the hours of occlusion was too much, that the compliance was too low.
Yes.
And hence the results of amblyopia were then again poor. So now that we have come up with lesser hours of occlusion, because still occlusion remains as the gold standard in the treatment. And now the compliance is better because the hours we found that from the various amblyopia studies over these decades, we have found it because Anitha, we belong to madam, and we belong to the era of this cam vision simulators and Amblyoptics.
Yes.
So when we wrote exams, and when we were asked questions, and we were asking questions, as you said, on Amblyoptics and cam vision simulators, which have become museum pieces as of now. We do not know. Something more on that may come up in the coming years. We do not know. That's another thing. So that was the era. But now the compliance has become better, and hence the results has become better, because the we have found that even shorter duration of occlusions give good results. That's one thing. And another thing, as you said, this I always used to tell the parents of my children with amblyopia, because many times what happens is you tell them to patch, they patch, the child goes out and does something, and after the hours of patching, whether it is 4 hours or 6 hours, 2 hours, they remove the patching. So I always tell them, you do something purposeful. So I tell the parents, mother, father, maybe some a grandparent who is interested, to sit with the child and do something near vision. But always to catch hold of a child 4 years, 5 years, 6 years, and do this near work for 2-3 years would be a bit 2-3 hours would be a bit difficult. But I tell them, in between you watch TV, do something purposeful.
Yes, sir.
rather than the child roaming around with the occluded. You do something purposeful that more hours of near work does the occlusion work better. That's what I always, as you said, no, I told my patients, parents, and as you said, no, motivating the parents and grandparents, and you'll have to spend a lot of time with the parents to tell them how it works and how much they have to dedicate their time with the child in getting a good result out of an amblyopia treatment. And I think maybe I was telling about 2 decades back. The coming 2 decades, I think more of neuromodulators, more of vision therapies are going to come up. That maybe when amblyopia is discussed 10 years, 20 years down the lane, I think results of amblyopia therapy is going to be much better. Thank you, Anitha.
Thank you very much, sir. Just one thing I would like to mention. I had once a patient who came, a boy who, a 20-year-old boy like this, he lost a job. He was going into army and he lost a job because he was amblyopic in one eye. So the mother who was with him told him that, he wouldn't patch. I had tried. He wouldn't wear his glasses. He wouldn't patch. And that the boy was telling him, Amma, I was unaware at that time. I was ignorant. You should have even beaten me or whatever you would have done. You should have done at that time. Now I narrate this episode to every mother or every father. I say, you will have to hear this at the age of 23. So if you don't want to hear this, make sure that that is one thing I tell them. And for boys, I usually tell them, do you want to drive? If you want a driving license, you patch. These are few things which, really, you can see the difference in them, that, they kind of get motivated.
Anitha, have you means after the next of penalization and all these things, have you tried any of the drugs?
No,
have you had to come to
no, actually drugs have not tried at all.
Anybody?
No, because they are still even if you like levodopa or carbidopa, the only ones which have been used, others are only under study. Citalopram and are all just under investigations only. But lots of revolutionary ideas coming up. If you just look up at the internet, check Google's, you have in the Google itself, it gives lots of games like this falling block game, dig rush games, and many other games which can be played by these amblyopic children. And I always tell them not to play in the mobile. Better is this laptop or the TV, smart TV, because they say larger the screen, the better, farther the screen, the better. That's what AO says. So according to that. Yeah.
Thank you.
I have a small question for both Manoj and Anitha.
Yes.
From your experience, post ROP children, what is the usual range of visual acuity that they improve after treatment? And Anitha, have you seen any of those, and do they improve with amblyopia therapies?
Yeah, they are also, I think they will also come under the stimulus deprivation category, and they are quite resistant to treatment. Very, very difficult for them to get motivated, especially if they are lasered and if they have like structural, the retinal issues are there. So amblyopia treatment is difficult, but I keep motivating and I try to get the best of it. Just like Madam said, they reach up to 618, 612, and then beyond that, it's very, very difficult to get up to 6.6. It's quite difficult, especially in treated ROP eyes. Dr. Manoj, what is your?
Yeah, I think you've said it all. Anatomically, many of these children may have macular ectopia, and this is something which may be very subtle, and this is one of the reasons why they have squint as well as amblyopia. So that is so anatomically when they have these issues, then these children do not so but then anyway, as you said rightly, our aim is to keep trying to make sometimes very unfortunate that that's why I put the first slide that there's no fault of the baby being born premature. So we'll have to actually keep following them up. And I was just as you were talking, I was just thinking. I started off by telling that that I'm a premature child myself. I'm actually amblyopic in one eye.
Oh.
Yeah, I have, yeah. So I I never realized this until I joined, ophthalmology. When I was looking at this with direct ophthalmoscope, and that's when I realized I was amblyopia. And so you have an example of a person sitting here who would not even realize that
Must be quite difficult for you without binocular vision for indirect ophthalmoscopy, right? Stereopsis.
yeah,
It must be
I
difficult.
I'm heavily relying on monocular people.
Thank you, Manoj. Thank you so much for sharing, because even I have only uniocular, not because of amblyopic, but I'm not able to focus with both eyes. But I've learned, I've adapted, and to able to operate. So
Exactly.
thank you so much for sharing. I'm not alone in this.
Is it true with most of the retina people?
So when many fellows they come and ask us when they have refractive around, they'll ask us if they can do macular surgery. And I always tell them that I'm amblyoptic, I'm able to do good macular work. So
That's great.
In this context, I would like to tell the PGs. I think there are a lot of PGs, is it, in this forum, because in this context you can read regarding the monocular clues of for which yes.
Stereopsis.
So, and this is previously, I do not know whether now in the exams they are asked, but it's very, very important. Two senior ophthalmologists had given you the impetus to read that. So today or tomorrow, today it's already 8:30. So at least tomorrow you read up the what are the I think previously it used to be an very common question in the DO as well as MS exams, monocular clues.
Yes. Yeah. And Dr. Manoj, that slide of yours was so I yawn when I listen more. Please do talk. That was quite a good one.
just to make it a little light, because
yeah.
So in between, not only that, in between, there were a few. Because I think Manoj didn't stress on that, but that was a bit relaxing.
Yeah, very nice. Very few cute baby photos were really very nice. Yeah.
I was just thinking that, amblyopia is, whatever vision is left, we have lost some vision, whatever vision is left, we sort of stretch it out to come back to normal. And that is why neuroplasticity is, taking such, is going on and increasing by leaps and bounds everywhere. But that is important for all my PGs to realize, neuroplasticity can be practiced in us also. But please don't play the video games that Madam had explained. I think just reading the ophthalm books would be more than enough.
Right. Any more questions? Then otherwise we'll wind up. Okay. Okay. Thank you all. What is the next?
Thank you very much.
Okay.
It was very nice. Sheldon and Jasmine, real congrats to both of you and the whole team.
Whole
The
department.
topics were very nice.
Whole
We all enjoyed, learned a lot, at least refreshed a lot in amblyopia and all this. So it was very, very nice. And I think the attendance also is very great. At a time it was 52 or so.
Yes,
okay.
Yes. Really good participation.
Thank you all. Thank you, Manoj. Thank you, Anitha.
Thank you very much. Thank you, Dr. Sheldon.
Thank you, Dr. Anitha. An excellent talk. Being a retina person, we never get to hear other talks. And basics of amblyopia, she like a teacher now. She's like going through each and every step very, very clearly. And for the first time, I realized that I understood amblyopia much better.
Thank you very much, Dr. Manoj. Really nice.
Let me now invite Dr. Hari Ramakrishnan, Associate Professor, Ophthalmology Department, for the vote of thanks.
Hope I'm audible. Thank you, Aina.
Yes, sir.
So let me first thank our director, Dr. Bennett Abraham, who was the person who conceived this very idea of having a teaching session like this. I would also like to thank our principal, Dr. Anusha Merlin, for her support. I would like to thank Dr. Chitra Raghavan for her support. They called her for arranging the sessions and all that. A special thanks to all the senior members of the Trivandrum Ophthalmic Club who have joined us today. Special thanks to Sahasranamam sir for the points he put in towards the end of the sessions. And the next person to thank is sitting right next to me here. She have to thank her formally now. So she is the chairperson for the session. So thank you, Dr. Sushila Vinayer. And going on to thank our speakers, Manoj sir and Anitha madam. Manoj sir, when I called her, we had fixed the topic as ROP. We knew that there was no better person to call, but I was really worried whether he would get the time to join us today. But he readily agreed as soon as I called him. So that shows his interest in postgraduate teaching. Thank you very much, sir, for being with us today. And Anitha madam, again, I have to thank her formally. Anyway, she is a part of our own family. So she had some other plans for today, but then I just told her about the alumni meeting and the teaching sessions. She readily agreed, which I knew that she would. So thank you very much, madam, for the talk. And Manoj sir and Anitha madam, the session was excellent. Thank you very much for the sessions. Now it's my duty to thank our head of the department, Dr. Sheldon Goodino and Jasmine. So they took the major chunk of the responsibility in organizing this CME, though they delegated small parts of it to some of us. So thank you very much for what you have done. And my sincere thanks to my colleagues, Dr. Shimna CP, Associate Professor, and Dr. Susha, Assistant Professor, who were in charge of the publicity of the CME. And I thank all the postgraduate students and the consultants who have joined, members of the Trivandrum Ophthalmic Club who have joined for today's session. And a special thanks to all our alumni who have joined the session from different parts of the state, different parts of the country, in fact. So thank you very much. Thank you, one and all. Thank you.